Multiple sclerosis. Lesson 4 of 6. Definition. Multiple sclerosis is a chronic progressive degenerative autoimmune disorder of the central nervous system, CNS. It is characterized by disseminated demyelination of the brain, spinal cord, and optic nerve fibers. The disease usually affects those between the ages of 20 and 50, with the average onset being between 30 and 35. 75% of individuals diagnosed with MS in Canada are female. Image source: www.linkedin.com/pulse/demyelination-remyelination-dominic. /adbolt/. Multiple sclerosis causes damage to the myelin sheath, the protective covering that surrounds nerve fibers in the brain, nerves leading to the eye, and the spinal cord. Etiology and pathophysiology. Ultimately, the cause of multiple sclerosis is unknown. It is autoimmune in nature, where the demyelination continues with progressive loss of nerve function. One thought is that a person who is susceptible to the disease may develop it after environmental exposure, such as an infection. Precipitating factors include infection, smoking, physical injury, emotional stress, fatigue, pregnancy, and poor health. Multiple genes that confer the susceptibility of an individual to develop this disease have been identified. 3 processes are involved with MS: chronic inflammation, demyelination, and gliosis of the central nervous system. MS is characterized by cycles of active symptoms and remission. This is because the myelin sheath can regenerate. However, over time, with subsequent attacks, the axon becomes involved and glial scar tissue forms. Glial scar tissue prevents the reformation of myelin and the ability of the nerve to transmit impulses, resulting in permanent loss of function. Image source: health.self-decode.com/blog/causes-risk-factors-of- multiple-sclerosis/. After an unknown trigger, an autoimmune response is initiated. During the response, T cells are activated and circulate through the body. The T cells reach the central nervous system, disrupting the blood-brain barrier. This creates an antigen-antibody reaction leading to inflammation and demyelination. Clinical manifestations. The progression of MS is slow and gradual, with minor symptoms that individuals may not consider to be of concern. Some individuals may experience more rapid progressive deterioration. As previously discussed, MS is characterized by remissions and exacerbations, where each exacerbation results in increased neuron damage and, as a result, more permanent symptoms. Symptoms can vary from individual to individual depending on the area of the central nervous system that is impacted. Common signs and symptoms include motor, sensory, cerebellar, and emotional impacts. Image source: www.verywellhealth.com/how-ms-affects-muscles-415856. 5. Motor symptoms include weakness, paralysis, diplopia, double vision. Scanning speech, slowed speech with frequent breaks and variations in tone. Muscle spasticity. Image source: nanimedot Companies AWP. Sensory development in early childhood. Sensory symptoms include paresthesias, feeling of tingling, numbness or pins and needles, patchy blindness, blurred vision, vertigo, tinnitus, decreased hearing, neuropathic pain, radicular nerve root pain. Lermit-sign transient, feels like an electric shock down the spine into the limbs with neck flexion. Image source: www.frontiersin.org/10.3389/fnur.2020.00529/full. Cerebellar symptoms include nystagmus, repetitive eye movements, ataxia, coordination concerns, dysarthria, difficulty speaking, dysphagia, difficulty swallowing. Image source: www.verywellhealth.com/emotional-symptoms-and-multiple-sclerosis-4588077. Emotional and psychological symptoms include anger, grief, euphoria, behavioral changes, depression. Common MS manifestations, diagnosis, Due to the pathophysiology of MS, there is not a single diagnostic test that can be used for diagnosis. Instead, assessments, including history taking, evaluation of manifestations, and diagnostic tests, are utilized to come to a diagnosis. Diagnostics, history and physical examination, CT and MRI, visualization of plaques, inflammation and atrophy, CSF analysis to determine if immunoglobulin G and oligoclonal bands are present, evoked response therapy to determine if responses are delayed due to decreased nerve conduction from the eye and ear to the brain. To be diagnosed with MS, the individual must have at least 2 inflammatory demyelinating lesions in at least 2 different locations, damage or an exacerbation occurring at different times, and all other differential diagnoses need to be ruled out. Treatment. Treatment is multifactorial and includes medication therapy, alternative therapies, and nutritional management. Medication. Patient teaching. Corticosteroids. X. Prednisone. Methylprednisolone. Restrict salt intake. Do not abruptly stop therapy. Be aware of possible medication interactions. Immunomodulators. X. Interferon beta. Perform self-injection techniques. Report adverse effects. Cholinergic. X. Neostigmine. Consult with healthcare provider before using other medications, including OTCs. Anticholinergics. X. Oxybutynin. Consulting healthcare provider before using other medications, especially sleeping aids and antihistamines, muscle relaxants. X. Diazepam. Baclofen. Avoid driving and similar activities due to sedative effects. Do not abruptly stop therapy. Avoid use with tranquilizers and alcohol. Acetylcholinesterase inhibitors. EX. Donepezil. Maintain adequate hydration of 2 to 3 L of fluid per day. Rise slowly when getting up from a sitting or lying position. Report persistent abdominal discomfort, increased salivation, unresolved diarrhea, increased muscle pain, visual changes, or shortness of breath. Sphingosine 1-phosphate receptor modulator. X. Fingolimod may increase the risk for infections and reduce the effectiveness of influenza and tetanus boosters. Alternative therapies and nutritional therapy. Therapies are aimed at decreasing symptoms and increasing quality of life. There are nutritional recommendations, but research has not found a specific prescribed diet recommended for MS surgical interventions. Neurectomy, removal of a nerve. Rhizotomy, killing nerve fibers to decrease pain. Chordotomy, destroying the pain-conducting tracts of the spinal cord. Dorsal column electrical stimulation. Implantable neuromodulation device that sends electrical signals to selected areas of the spinal cord to decrease pain. Alternative therapies. Physiotherapy, exercise improves daily functioning, decreases spasticity, increases coordination and muscle strength, and improves gait and mobilization. Water exercise is recommended as bouncy decreases the stress on muscles, making it easier for individuals to participate. Heat therapy, massage therapy, acupuncture, aromatherapy, stem cell therapy, nutritional therapy, megavitamin therapy that includes cobalamin, vitamin B12 and vitamin C, vitamin D supplements, low-fat, gluten-free diet with lots of raw vegetables. Nursing assessment. Nursing assessment is going to focus on evaluating for predisposing factors such as environmental triggers, clinical manifestations, and head-to-toe assessment. Subjective data. Past health history including infections, vaccinations, residence, stressors, pregnancy, exposure to heat and cold, and family history. Medications, use of corticosteroids, immunomodulators, immunosuppressants, selective adhesion molecule inhibitor, cholinergic, anticholinergics, antispasmodics, antivirals. Symptoms. Review common clinical manifestations image above. Objective data. General observation for mood, inattentiveness. Neurological assessment evaluating for speech irregularities, nystagmus, ataxia, tremors, spasticity, hyperreflexia, decreased hearing. Musculoskeletal assessment evaluating for weakness, paralysis, paresis, spasms, gait irregularities, dysarthria. Diagnostic tests. Review diagnostic test information. Possible priority concerns, problems, mental health concerns, weight management, swallowing difficulty and risk for aspiration, mobility concerns and risk for falls, incontinence, muscle spasticity and control concerns, risk for infection, visual disturbances. After identifying the priority concerns, it is essential to develop a plan of care to address these concerns. This will involve identifying symptoms and experiences, considering interventions to assist with the problem, and evaluating their outcomes. Nursing goals. Nursing goals include maximizing neuromuscular function, maintaining independence in activities of daily living, managing fatigue, optimizing psychosocial well-being, adjusting to the illness, reducing precipitating exacerbations. Nursing interventions. Interventions provided are going to be dependent on the symptoms that the individual is experiencing. Health teaching will be of paramount importance to assist individuals with identifying precipitating factors and how to reduce them, encouraging sleep, good nutrition, decreasing stress, adhering to medication regimes and possible side effects, potential manifestations that can be experienced during an exacerbation, and when to seek medical assistance suspected infection. Based on the symptoms experienced, take time to consider multidisciplinary team members that the individual should be referred to, such as a speech-language pathologist, physiotherapist, occupational therapist, massage therapist, dietitian, and pharmacist. After providing interventions, the outcomes must be evaluated to determine their effectiveness. If the outcome does not improve, consider alternate interventions and approaches.